Good evening, everyone. Welcome to session 19 of the SCTS Foundation Doctor Academy. It's my absolute pleasure to be joined by Mr. Stephen Large, who's a consultant cardiac and transplant surgeon at the Royal Papworth Hospital in Cambridge. After being appointed consultant in '89 and being a consultant for a third of a century, he's pushed boundaries in cardiac surgery and cardiac transplantation in a number of ways, including being the lead surgeon on the first DCD heart transplant in Europe back in 2015. So it's an absolute pleasure to have you with us, Mr. Large. And without further delay, over to you.
Thank you very much indeed. It's a great pleasure to do this, and it's nice to know that people are interested in what's been a fascinating time. Actually, it's a very young subject that we're in, but you've charged me with looking at cardiothoracic transplantation and a mechanical support. You're going to get quite a lot on heart. You're going to get very little on thoracic and very little on mechanical assist, but we'll slip it in. And do feel free with this session, just butt in. So you know that you've got this that tells you what your learning objectives are. They're perhaps a little ambitious, but we'll see how it goes anyway. So it is a pretty interesting time actually, because this tinker here, this fella, is a South African who was undoubtedly very bright, working in Groote and one of that group of people who simply have dexterity woven into their system. He was a very able surgeon. And on the pretext of looking at the newly emerging renal transplantation, which had happened in the 50s in Boston, he went over to the States to look at what was going on there, but with a particular eye to what Norman Shumway was doing in Stanford. And he came back armed with good conversations and emerging protocols to deal with the mechanics of heart transplantation. And on the 3rd of December, '67, with his brother, Marius Barnard, who ran the donor operation, a young girl who was run over in Cape Town, a white girl, thank God, because we were all watching in horror as these events emerged, and the young girl's heart was seen to stop in Groote, which is actually Afrikaans for barnyard. So they're the Barnards of the barnyard, and Marius resuscitated the heart, the donor's heart, with bypass, excluding the cerebral circulation, and then took the heart when his brother Christian was ready with the recipient, Louis Wachensky, in the next door theatre. And if you find yourself in South Africa, in Cape Town, it is, I have to confess, a fascinating museum, which is the actual theatres in which all of this was done. So you need to know a bit about heart failure, and it's a syndrome, and it's very easy to define. It's really a failure of supply of the demands for cardiac output. But there's been a recent caveat saying you can't call hypovolemia heart failure. It's a sort of acute heart failure, but corrected rather strangely with volume, with reestablishing the circulatory volume, and so the cardiac output, and so the shortfall in requirements for cardiac output. So why are we not getting here? Here we go. So the etiology, I've said, is not enough blood. It doesn't count, but it's worth putting in there to dismiss it. An inability to fill in diastole, either because of mitral or tricuspid obstruction, or degrees of obstruction. Problems with mediastinal shift, so it's difficult for blood to enter the right side of the heart, tension pneumothorax, tamponade. What sort of pressures do we need in the intrapericardial, extracardiac environment to stop the heart filling? Your CVP is about 5 centimeters, 5 millimeters of mercury. And so not very much pressure at all. So fail to fill the atria, and you can't fill the ventricles. And as a result, with very low increased pressures in the pericardium, do you find that you get a situation where you can't fill the heart, and therefore if you can't fill, you've got nothing to pump, and you enter the definition of circulatory failure, of heart failure. So tamponade is a thing we are terrified of in cardiac surgery. So hence the preoccupation with draining the pericardial space after surgery to make sure as little as is possible in the way of blood or edema or whatever it gets into the pericardial space and embarrasses diastole the filling of the atria and therefore the ventricles. And then, of course, you've got the stiff ventricle with myocarditis and inflammatory condition, cardiomyopathies, and the infiltrative issues. So hypertrophic cardiomyopathy is really bulky ventricle and therefore very stiff, bags an excess, if you will, of systole. And with HOCM, with hypertrophic cardiomyopathy, you have to come to that patient, and we see them regularly because of the obstructive nature to the outflow tract of hypertrophic cardiomyopathy. They can be they present with diastolic problems, filling problems, because there's not much space, and what space there is compromised by a very stiff, not very elastic ventricle. And then infiltrative problems like amyloid and Fabry's and so on. So you can see normal systole, and you'd say, well, how can that be failing? And it fails, of course, because it can't fill. And that's the category of patients who have HFpEF. You probably heard that, heart failure with preserved left ventricular function. And so that's impaired filling. And then the next one is impaired emptying, not enough muscle action. You've got a dodgy ischemic heart, and 50% of the people we operate on are now as a result of ischemic loss of myocytes. Arrhythmia, intrusive arrhythmias, have as many myocytes as you like, but if oh, I'm sorry, this is skipping ahead, isn't it? How do we get back? Arrhythmias, most often atrial, associated with heart failure and increasing age, will upset function, overall cardiac function considerably, up to 30% reduction in cardiac output. And of course, ventricular arrhythmias are very intrusive. You lose your atrial transport, that 30% kick. But of course, if you're in VF, there will be no forward flow. So acute lethal heart failure. And you present, I'm sorry, I'm showing you signs. What's the matter with me? Impaired filling, we're on impaired emptying. And then, of course, obstruction with pulmonary valvular stenosis, pulmonary artery stenosis, be it congenital or from a pulmonary embolus, a massive pulmonary embolus, a central pulmonary embolus that blocks the main trunk of the pulmonary artery. It's a lethal condition. And aortic valve stenosis, and of course, large air embolus, which presents as a sort of a distensible series of bubbles that are a very effective block to forward flow once they get into the pulmonary circulation. You need quite a lot of gas into the right side to block forward flow. So the symptoms, I'm sorry, I beg your pardon. You have to read in light. Fatigue, they're all rather nondescript. Fatigue, lassitude, kind of like you feel after finals, or a rather pathetic attempt at running a marathon. You do about 100 yards and feel fatigued, lassitude, giddiness in my case, faints, reduced exercise tolerance. That is, you get increasingly breathless. And this can be dramatic when you see it to be positional. We had one guy who was very young, and he's on the other side of London. They rang and said, no one in London can have him. He's 27. We can't lie him flat. He's desperate. He's got an acute myocarditis, we believe. So can we in the ambulance bring him to you in Cambridge? And I said, well, if he's that sick, he's probably not going to survive. But he came up to us, and they rang again. They rang again on the M11, the road up to Cambridge from London, saying they're running out of juice on the ambulance because they had so much supportive device with ventilators and so on, and or respiratory assist. And so they stopped off at the service station, and I said, just unplug the machine and whatever it is, and plug your ambulance in, charge your batteries, and when you get a chance, come up here, and we're all ready for him in the operating room. Anyway, the long and the short of it is he arrived incredibly sick, and he rounded up having biventricular assist. He was too sick to survive, quite honestly, the next few moments, the next few hours. And he went on to tell me at 5 months, with his increasing sepsis from his percutaneous left and right sided ventricular assist devices, that he had recovered from his acute myocarditis, something we recognize now, but we didn't know happened in those days. And we had to take the devices out to save his life. But of course, removal of the devices, I said, will probably, the balance of probabilities, be the end of you. And he's alive and well many decades later, and incredibly well. And we repaired him, and that we supported him through his acute inflammation of his myocardium. And it's a hideous room to be in, because you realize the shortcomings of heart transplantation. He was followed by a young girl of 17, a short while later, exactly the same story. But anyway, I'm telling you that because of the profundity of the positional nature. He couldn't lie flat. And so what we did was to put him on bypass with him sitting up under local anesthetic through his groin. And we switched on the machine to 5 liters a minute. He just said, "Hey, I feel great." And so the power of the pump, it's wonderful, be it mechanical or God-given. Signs, there's weight gain, there's positional edema, it's dependent edema. So if you're lying on your back, it's on your back. If you're lying on your front, it's on your front. If you're standing up, it's down your sacral pad and your ankles. And you may find an arrhythmia. It's a very common association with heart failure, and a very common association with aging. You'll get peculiar distribution of water. If you remember, your guide to this is Starling's law of the microcirculation, where your principal problem is venous hypertension, insisting that the water doesn't drain back into the circulation, but remains in the interstitium at the microcircular level. And so you get edema all over the place, including the peritoneum. And that we recognize as and call ascites. And you get a very congested liver, which indeed can be pulsatile if you've got tricuspid regurgitation and a really severely incompetent tricuspid valve. You'll see that also as a raised JVP with a prominent ventricular wave, or V wave, in the neck. Often you can miss it because the venous pressure, the central venous pressure, is so high that you can't, even lying the patient flat or sitting bolt upright, can you get it down to a level where you can appreciate that it's there. The telltale is to let the patient just sit quietly in bed, not talk to them. Quite a difficult moment because patients like to chat, and you'll see the earlobes wobbling in sympathy with the pulse. And if you do see with a almost erect patient a V wave, look for the associated preceding A wave, the atrial wave, because then you can say, oh, he's in sinus rhythm with that A-V synchrony seen on his venous pressure. He may, of course, have positional sores, pressure sores, because he's not in a position really to get up and get about. So look at his heels, look at his back, and make sure that they're reasonably nourished with not only the pressure of lying on pressure points, but also the rather poor cardiac output, which will drive together to make skin breakdown. So recognizing heart failure, this is nicked from a NIHR, sorry, I beg your pardon, an American, NIHR website, and it's a complicated English, but it's a prevalent clinical syndrome. It's a common clinical syndrome associated with a huge amount of cost, both to well-being, to life, and to the national budget. We spend about 2% of gross national product, somewhere between 1% and 2% of gross national product on heart failure in this country. There are ways forward with management of the syndrome, but it's very expensive. Heart transplantation is very expensive, and certainly devices are very expensive, and we've managed through the elegant diplomacy that I have, which is a thing called bullying, to get top slicing in the NHS for covering the cost of very expensive implantable ventricular assist devices, little pumps, which are horrendously expensive. And it's important to win the arguments with these very expensive solutions by looking at quality of life and quality adjusted life years, so that you can win the argument on grounds of economy and healthcare spending. And I think we're doing a good job there. We're a bit nervous about costing transplantation because it really is extremely expensive. There is very, very good, well-supported randomized data showing that angiotensin converting enzyme inhibitors and beta blockers and diuretics, I'm not sure why digoxin is here, diuretics are life-saving and proven to be so. And so patients will be given these almost by reflex now. Digoxin, we use, I think I may be a bit old hat, but I don't think there's been very good trials on digoxin just yet. But we assume that it's an oral positive catecholamine, and it has a sort of, if you will, a sort of inotropic effect, and it's quite useful in thrashing out some increased activity from a failing myocardium. So we use it even if the patient isn't in atrial fibrillation. And these are cheap drugs, and they're very effective. What's emerging now is the issue of trying to get the right ventricle and left ventricles to contract as they do in you and me. And it's taken me a long time to realize that the left ventricle is like an ice cream cone. It's its own little agent. Onto it is plugged a Klingon, which is not a complete cone, but a sort of cone with a slice out of one side, and it sticks itself, does the right ventricle, onto the left ventricle. So if it's contracting, it needs to contract against a contracting left ventricle. Otherwise, you have a contracting right ventricular free wall against a flaccid septum, and you go into right ventricular failure very quickly. So resynchronization therapy is incredibly useful with some staggeringly good results. I've got a patient who, age 17, was stabbed through the heart in St. Petersburg, and we've put him back together again, and he's got deterioration with time. Our operation was the fourth 2 decades ago now, and he's presenting with acquired mitral regurgitation, and resynchronization therapy has got him back to really away from hinting of severe mitral regurgitation to almost mild, and he's spectacular. He's an artist, a very celebrated portrait painter in this country, and so pacing is good. And then, of course, mechanical circulation, circulatory devices, which are eye-wateringly expensive, and it took a lot to get the local health authorities to part with, in the days when I was doing it, back in kind of the turn of this millennium, about £170,000 they had to commit to supporting this. And they would say in the emergency phone call I put through to them that they'd get back to me on the condition in due course. And I had to explain to them that really wasn't tenable, because the patient was dying, will probably be dead in the next 3 or 4 hours. And then that was always followed by, almost as a scripted event, by a series of fairly well-known expletives from the most mild people, and effing and blinding, with graphic descriptions of why they got into public health and to get away from these decisions. And that won us the, not just me alone, Magda Yaku was doing the same down in London. And they got the public, the healthcare physicians got fed up with this berating. So we won this top slicing and a national program of ventricular assist. And we'll come into that very quickly. I'm going to push you now into the direction of lung failure merely to dismiss it. There's a lovely definition. This is a super one. It's just a condition that makes it difficult to breathe on your own. And that's a great definition because it's exactly what the condition is. The problem, of course, is a failure to get sufficient oxygen into your blood. And that's either because of a loss of ambient oxygen, a restriction of your ability to draw air into the airways now, and therefore the alveoli, a barrier to diffusion of the alveolar capillary wall, or a restriction to exhalation in the form, for example, of asthma, bronchomalacia, or some such problem. So impairing respiration. And that kind of encapsulates the etiology. And what do we do about it? This here shows me ringing the right lung. We can ring the left lung, do single lung transplantation. And a lot of patients over the last 1.5 centuries, is that fair? Last century really, have managed very well on pneumonectomy, the right lung being 55% of lung volume, the left somewhat less, 45% of course. And so folk can lead a reasonable life with one lung and an empty hemithorax, contracted hemithorax after the resection of the lung. We can go on to do bilateral lung replacement when there's really an infiltrative process like a fibrosing alveolitis and impairing that gas diffusion. And so insufficient for one lung, so patients get both. And then, of course, we can do heart and lung transplantation, which is really, when I came on the scene here, my colleague John Warwick had imported heart and lung transplantation from Stanford. And we had the lungs connected to the heart. We would open the chest, remove the heart, remove the lungs, leaving a stump of bronchus and a right atrium and an aorta, so 3 anastomoses. So it was very straightforward implantation. It was usually a misery taking these organs out because of long-standing scarring, infections, fibrosis, inflammation with dense adhesions to the chest walls. So we don't do so much heart and lung transplantation anymore, but that's basically lung transplantation. This is as much as you're going to get from me, so I can tick the box that you're at least aware of it. And I've got here, of course, we've reproduced this slide on mechanical assist. So here, years back, we're preparing a heart from a heart-beating donor. We've cardiopleged it. The patient's been found to have brainstem death and is a multi-organ donor. And we've taken the heart here. We're just trimming it up, ready for implantation. And here in heart transplantation, we look to remove the heart from the aorta, from the pulmonary artery, and from the venous connections, the right and left atria, bluntly. And so we're left with artery, the 2 arteries, the proximal arch of the aorta, the pulmonary artery before its bifurcation, the right atrium, snares on the pipes so that we don't get any indrawing of air, and the left atrium with its pulmonary venous connections. And then we just sew left atrium to left atrium, right atrium to right atrium, aorta to aorta, pulmonary artery to pulmonary artery. And it looks a bit like that at the end. And this is a little bit more graphic. It looks, that's the sort of picture. And here we've moved to not atrial anastomoses, but bicaval anastomoses. In that way, we get the pump back plugged into the 2 pumps, there's a right and a left, into the 2 circulations, the pulmonary and the respiratory. Is it commonly done? Across the years, we had a peak here in the 90s when in this country we were doing something like just under 400 heart transplants a year. And it dwindled. And here we are, I think we're obscured in yellow here. And we've got really quite low in 2001. And with learning from Spain, particularly, they are amazing. Be very careful when you go to Spain, because if you want organ donation, you just chuck a euro on the ground, somebody bends over to pick it up, and you'll suddenly find yourself on a heart resuscitation program and donating your organs. I am being glib, by the way, but it's they are very, very keen on organ donation, and it's how we should be. Here in green is North America, and they're doing wonderful things there, but sadly, of course, at the moment, we've got the problems of two beautiful drugs that have been produced by Purdue Pharma, two extraordinary analgesics, fentanyl and OxyContin. They are amazing. I had pancreatitis in 2018, and the only drug that got rid of the pain was OxyContin, and I was allowed 3 days of it, but it removed any vestige of pain at all. It was quite extraordinary. Red is the rest of the world. And these are the results of the International Society of Heart and Lung Transplantation. Here are the results graphically in epochs, that those early years of the emergence. we restarted heart transplantation here after the excitement of the Barnard's work in 67. There was a boom in 68 with untold destruction and huge deaths. One or two centers, of course, Stanford, continue with great results. And emergence began in Europe in 79 and began in Papworth in 79 with Terence English. And the little bit of confidence emerged to give us a World Series. And you can see here the deterioration across time, but we're looking not at a paltry x-axis, but going out to 22 years. What I've put here is the average survival, the likelihood of survival, if you were a patient recruited to Eric Rose's study of implantable left ventricular assist. He had a control group and a group that were randomly allocated to ventricular assist devices. This was a group of patients for whatever reason, either their choice or because there was some peculiarity that denied them access to transplantation. And they, of course, had consented to this rematch trial, as it was called. So if you're in the control group, you've got a 50-50 chance of surviving 1 year. So heart transplantation is, whatever one says about it, and I'm very derogatory about it, it does have a massive impact on your prognosis. And you can see here over the years, as we go from blue through to purple, there are parallel lines showing an increased survival with time, but not a change really in the rate of deterioration, rate of death annually after this intrusive period here. We're just probably getting better at managing the perioperative patient, selecting the right people, selecting the right organs, perhaps. So we can say dramatically prognostic value added here in our ISHLT graph. And so here is the best that the ISHLT do in terms of quality of life. And they've looked at Karnofsky scoring, and it's a fairly crude system, but basically green, yellow, and red describe various declensions of independent living. And so this is 1 year and 5 years in a fairly substantial number of patients. It's a very effective improvement too in your quality of life. So it's not a normal one, it's near normal, but it's not normal to take immune suppressant drugs, which is a lifelong prescription. Things are different, of course, in terms of etiology between adults and pediatrics. Pediatric is really size, quite honestly, and we look at pediatrics of less than 50 kilograms body weight, and above that weight, we record the patient as adults. And we're looking essentially cardiomyopathy and congenital heart disease here in blue, the pediatric survival. But it looks as though getting a heart into a youngster has an overall better prognosis, not just a short attrition here, but a much better rate, a much more attractive annual loss or moment by moment loss of recipients. And here is the very familiar attrition over again, quarter of a century. So very impressive results with heart transplantation, however rude I've been about it. We talk about conditional survival here, where we take away the mischief in the first, quite honestly, month or even 3 months maximum. But we actually say after the first year, what is this rate of decline? And it's the life expectancy once we've knocked that out is of the order of 13.9 years, and it is extraordinary. And here the ISHLT figures to tell us the average age of recipient. And this is kind of gated, as you might imagine, by is created really by availability of donor organs, as we'll see in a second. The people who are getting transplanted are young people, basically, and the similar attitudes would seem to be prevalent in Europe, North America, and here and in the rest of the world. Perhaps an even younger group of people going forward for heart transplantation. Look at, in contrast to the donors, and in Europe, we do not have widespread young death, and an unsung celebration really of public health is, in my time, since '89, there's been a reduction of road traffic deaths from 7,500 per year to 1,500, and anybody making a 6,000 life saving should really be celebrated to the heights. And that's what folk have done with sensible changes like speed restrictions, crash helmets, safety belts, and so on. Not great news if you're on the waiting list for a transplant, but wonderful news if you're a nervous driver, as I am. And here in the rest of the world, caution with organ donation, and in the States, they're really doing very well. But still, nonetheless, with everything that's going for them in the way of the only positive side of the liberal gun laws they have, and the extraordinary use of the powerful agents for drug abuse, they have still fall short in the requirement for organ donation to meet supply. So there is a tendency to match donor age for recipient age. So, sorry, beg your pardon. So if we go out to a 70-year-old, we will in this country treat the odd 70-year-old, but most of our patients are really in their 50s and 60s. Here in the adult area, obviously in Great Ormond Street in Newcastle, they're pediatric. So we're just not quite matching donor age for recipient age, but near as damn it. This is a bit of skullduggery. It's less of an issue now when I think people are used to the idea of heart transplantation, but every centre had to have a claim to heart transplantation. So you see 75 plus, where, I beg your pardon, sorry, here 1 to 19 heart transplants done annually in a huge number of units worldwide, and the really busy centres where this sort of area at the moment, I'm sorry to say, we were touching on this not so long ago. This is quite rare to have a particular focus on transplantation, and it's a good thing to do large volumes. You just, in general, you tend to get better results. Sorry about me muttering in the background. Let me just, on top of that, let's get rid of that. How do we get rid of that? So here, what we've got here is an important picture. Here is the NHS Blood and Transplant Authority saying, here we've got 100% of our organ offers. Are you interested in the liver? Yes. And are we worrying about age? Not so much. Down here is age. What about consent? Great news for consent. And organs are offered, organs are retrieved for transplantation, and a little decline between retrieval and those accepted for implantation. So we're seeing sort of 80% or so of offers being taken up and indeed transplanted for liver and kidneys. Change to the heart, and we find that we're a little bit ageist. Is that appropriate? It may be, and we're worrying about coronary artery disease. It's difficult getting a coronary angiogram or description of the coronary arteries. So we lose a number here. And then we look for consent. We look for consent, organs offered in donation, organs retrieved, a huge drop-off between the offer, the effective offer of what looks like on the face of it, a good donor, to going out and retrieving them. And then once we've committed to retrieval, we tend to use what we've gone and taken. we're good at selecting, but probably over-selective, and probably a little bit cautious. So one in, what is that? 1 in 5 heart offers we reject. And that's not right. 1 in 5 heart offers offered we take. The other 4 are rejected, and they'll go forward, if possible, for valve banking or disposal. And lungs, I'm afraid to say, are in a worse state. Here shown in, where are we? Is in the pink dots. So slightly worse than hearts. And we shouldn't be in that state. I'm not sure what's going on there. Perhaps it's not quite so exciting to put a lung in as it is to put a heart in. So why have I not got activity here? I'm sorry, I had a picture here showing a gradual decline. Just imagine you can see a histogram here over 2 decades showing essentially a decline in cardiac transplant activity. NHSBT would tell me I'm a bit pessimistic. There's been a bit of an edge upwards, but we're looking around not the near 400s of 1990s, but knocking on the door of 200 a year, and trying to concentrate and really push folk to use, be a little bit more aggressive in the use of the donors offered. But we see that the waiting list continues to climb despite that, as you'd expect. And indeed, in the States, waiting lists tend to continue to increase despite their abundance of supply or apparent abundance. We would see it as a huge benefit. We've modeled heart-beating donation. That is where people are brainstem dead for whatever reason, most commonly here now, not road traffic accidents, as I've implied, but by unfortunate hypoxic death as a result of drug overdose or accidental respiratory crises. And we see that we get modeling here with the model of a rising intracranial pressure. We get a reflex of hypertension, which lasts essentially for about half an hour, and an associated tachycardia, which is a little bit longer than that. And it would seem that this is a result of what the Nowitzki, working in South Africa with the Barnards, showed rather elegantly of noradrenaline, dopamine, and adrenaline-like substances within the first few minutes, out to, he's saying, of the order of 3 hours, with this is the catecholamine storm, the consequence of brainstem herniation and brain death, the resultant of which is the heart-beating donor with no respiratory drive, just simply heart beating because the patient is being ventilated. We've modeled looking at this. We were interested in this whole area, so we do these pressure volume loops. So sorry about this, it takes you back to a bit of physiology. We've got a machine that will sit in the ventricle, and it will look at the volume. It'll calculate the volume by electrical conductance within the ventricle instantaneously at the same time as the pressure. So here we're recording volume, here we're recording pressure. So diastole, lowest point in terms of volume. It's an empty heart. It slowly fills without much change in pressure, but considerable improvement in diastole in terms of volume. And then there is myocyte contraction, and you get isovolumetric, same volume, pressure, until you reach ventricular pressure, reaches the diastolic pressure in the aorta, the systemic arterial system. The aortic valve opens, and you get a net reduction in ventricular volume. We're following this guy here. So you get ejection, and then to a point where you have a sympathetic closure, non-active closure of the aortic valve, and then you go into isovolumetric relaxation until you have a point at which the atria are slightly have a slightly greater pressure than the ventricle, and then you go round and round the circle. We change the amount of blood we allow into the heart, so we get a sort of loaf of bread-like picture of various volumes of blood that fills the heart, and we get these family of loops. We can join the end systolic points and say, okay, here is the contractility of the myocardium independent of filling. And so if you come to me and say, this guy's got a lousy ejection fraction, I'll just say, give a vasodilator and his ejection fraction will look better. I've knocked out the afterloading of the heart, and it will reward me by improving the cardiac index, the ejection fraction. Not so when you use a sensitive system that accounts for filling. And we can see also that a load independent, if you will, filling tells you about the distensibility of the ventricle. So we can talk about end systolic pressure volume relationship and diastolic pressure volume relationship. And it's rather more elegant and reproducible than the ejection fraction. So armed with this, we looked at a model of brainstem death in small mammals and large mammals. And here we see the end pressure volume relationship. It's sort of 15 squiggly bits, ESPVR. In you and me, if we had triple vessel disease and what seems to be a good pumping action on echo, going off to have bypass grafts, and a nice stretchy distensible heart with a nice looking pressure volume loop, EDPVR. Go through the rigors of brain death, let the whole condition settle down after those few hours, and you see a reduced ESPVR, it's halved, and a stiffer ventricle. So that's really, we're getting by no means a normal heart is the point of telling you about all of this. And so Siobhan Stoiker looked at 52 hearts. Here he's only put in 22 of them that were being taken from donors for hemodynamic studies, looking at end systolic volume and diastolic volume, stroke volume, heart rate, and ejection fraction, and showing that I've got your names actually in this. I can't show you that. Red, I think is it's anyway. I think that's the norm, and sorry, the red is the brainstem dead model, the donor, versus the apparently normal behaving left ventricle in people going forward for cardiac catheterization for coronary artery disease, for example. And so it looks as though the heart is a stretched ventricle, both in systole and diastole, seems to have an increased stroke volume because the patient is vasodilated and the afterload is good. The heart rate is up because we're no longer being governed by an intact brainstem, and the ejection fraction is down. And what I haven't included here is the pressure volume loop, which is much reduced. The ESPVR, the contractility, is much reduced in these people. So back in, where were we? We were looking at this really sort of 2010, quite honestly, wondering how the liver guys and the kidney guys kept going. And here in gray, National Health Service Blood and Transplant Authority has collected living donation. Not sadly, we're not allowed to do that. There's lots of people I'd like to recommend strongly to become living donors. But of course, this is lung and kidney and liver. And man, and the DCD, this is DBD is heart beating donation after brainstem death. And the numbers they've got in blue here increasing, but not really so for appropriate heart donation, being ageist and all. What we do see, though, behind all this sits a pale blue group of folk who've got not quite the criteria for death, but they are on futile therapy, and their relatives say, look, enough, you've done all you can, nothing's improving. The intensivists agree with them, and treatment, that life-sustaining treatment is withdrawn, that futile medical therapy is withdrawn. And so the point being made by liver and kidney surgeons back here in this sort of time, the first decade of this century, said, well, can we have the liver and kidneys? And I, about this sort of time here in sort of 2008 to 2012, was making a fuss with the donor ethics group, saying, well, I want the heart. And everybody was saying it's a dead heart. These are dead heart donors. And we'd modeled, as I've shown you, in rats and in pigs, and shown that there is a short period of time, and we'll go into that in a second, a short window where we can snaffle the heart out and recover its function and transplant it successfully. And this is non-heart-beating donation, or donation after circulatory determined death. And CD used to be cardiac death, but it's taken a long time to get people to stop saying that, because it doesn't help really. So we noticed that 35, I think, of our huge number of organ donors that we looked at retrospectively, that we'd had gone on to donate organs for as brainstem dead donors, heart-beating donors, ones who had a period of cardiac arrest recently before their harvest, their procurement of the heart, showed much the same outcome as those that had no such history. So we said, maybe a temporary period of arrest is not that important. And Ganot, who's my total pin-up hero, working with Jennings, the king of ischemia, myocardial ischemia, back in the 70s, worked on rats. And here, oh gosh, am I saying right thing? If it wasn't rats, it was dogs. I'm sorry to be quite so crass in my lack of understanding. But basically, denying oxygen at normothermia at 37 degrees centigrade, the heart would show no histologic change suggestive of irrecoverability. And my computer's just got a mind of its own, I'm sorry. And after 30 minutes, it seemed that there was a progressive rate of destruction, with game over at 55 minutes. There was no recoverable cell left within these specimens, these poor individuals, small mammals. So this is unusual, because when we talk about myocardial ischemia, all the models are regional. We're talking about global, the entire muscle. So a very different kettle of fish. And so, just taking on board what he said, we modeled in the poor old rat and the pig again, where we had rat heart bypass in Stanford. It was quite extraordinary. But we had a tiny little oxygenator and a little pump, and we would have these poor little scraps with a bypass available to resuscitate the patients, little creatures. And we saw hypotension, bradycardia, and eventual cardiac arrest. And we modeled for 15 minutes. And then we brought in our bypass, our extracorporeal membrane oxygenation reperfusion. And over a short period of time, we found ourselves with the situation that could be recovered with a bit of Pressor, a bit of vasopressin. And we regained a pulsatile circuit and a heart that looked in every respect perfectly reasonable. Looking at pressure volume loop in these individuals, controls that had actually, because of the manipulation onto the rig and so on, an ischemic time of 7 minutes, we saw no material change in the pressure volume loop contractility. And then at 30 minutes, similarly, much the same as Ganot had shown. And 60 minutes, we couldn't get the heart to beat. It was a complete wreck. So we hadn't really explored 35 minutes and so on, but we wanted to show crudely that we'd got this 30-minute window, and most people are happy with these results. We took a heart from a pig and put it in the mass spectrometer. And here we're looking specifically, same experimental design, exactly the same conditions, same readings. After withdrawal of oxygen, we're looking at phosphocreatine and the 3 phosphates of adenosine triphosphate in this mass spec. And we see after 15 minutes of arrest, lots of free phosphate, as you'd expect, much reduced in red here. This is the time coloration. Gross reduction in phosphocreatine, and a significant reduction in the 3 phosphates of ATP. So we go onto our resuscitation machine, we go onto bypass bluntly very quickly after 15 minutes of normothermic anoxia, and we see a trend over the course of 60 minutes towards repairing the levels of phosphocreatine, and and then we go slowly with some evidence of restoration of the 3-phosphates of adenosine. We ask the heart, which is beating, if we fill it, will it maintain the circuit, albeit not to the brain and the arms and legs, but to the chest and to the abdomen, thoracoabdominal normothermic regional perfusion. And it does that, and we'll see that in a second. And you see a significant return back towards control. And this we were very, very excited about. And Ayaz Ali is a great master of heart transplantation. Really, his PhD was in this area. He's now providing this service to the East Coast of the United States. We thought, because of the nature of what we were doing, that there would be no catecholamine storm, and we couldn't have been more wrong. It's about 10-fold greater than brainstem death. But the point is, the circulation is inept, and I think the damage done by catecholamines is not a primary insult of the agent itself, the adrenaline, noradrenaline, or dopamine in large quantities, but the consequences of its effects. It's increased inotropy, forcing against a very closed circuit and causing stretch and rupture of the myocytes of the contractile elements, which is recoverable, we believe. So we've seen this before. We modeled DCD transplantation here, and in the normal normal rat before we inflicted hypoxia, and found that we've got a very similar ESPVR 13.2 as we saw in the DBD folk, and similar sort of elasticity. And after recovering from ischemia, we saw, if anything, slightly better ESPVR than we saw in DBDs, and a much better EDPVR, which was great. So here we put together a line of how we would do transplantation. We withdraw in DCDs, life support, withdrawal of life-saving therapy. We made so many enemies by this stage. We simply accepted that functional warm ischemia was something the liver surgeons declared happened at a systolic of 50 millimeters of mercury, which in heart transplantation is not really very helpful. The heart, of course, is perfused in diastole. So why on earth you'd have a systolic determination of functional warm ischemia? God only knows. But we accepted it for assuming that at 50 millimeters of mercury systolic, we'd probably get a diastolic, which wasn't much different to the venous pressure, and therefore not much of a gradient across the myocardium. The clock started. We had a pulse. We had a standby time, a loss of pulse on peripheral arterial line of 5 minutes, and death was confirmed by independent groups, not by transplanters. And then we had to decide how we were going to manage the organ. You can cut out the organ and put it onto a machine, or you can go on to bypass and so this is ex situ donation. This is in situ donation, where we recover the heart inside. Here is an example of ex situ. This is the Transmedics, and you'll see the heart here, a pig heart, recovered, modeled and recovered on a Langendorf perfusion designed for this. And we'll go on fairly swiftly because that's all. Heart's pretty boring, actually, just beats. So we'll look now, same pathway. Here we are doing NRP, we're doing the heart and they're doing the abdomen. We're weaning the heart now to pump the circuit and switch off the machine. We can assess biventricular function, and then we can plege the heart, put it onto this machine, a Langendorf, the Transmedics, and transport it back like this, watching it from time to time from the donor hospital to the recipient hospital. And folk have been out to, I'm told, 10.25 hours, which is a bit lively. We've been out to about 7.5 hours with a functioning heart. So it helps a great deal in those the challenges of transportation. We started our program in 2015, but we eventually got the DCD program going. And here we had the bulk of the work we've done is ex situ. We take the heart, put it on the machine, recover the function of the machine. A small number, 23 cases of the now 120 we've done, were resuscitated within the body. and with remarkable results. But they're small numbers, and it's easy to jump to conclusions. There's also a hint too that we probably get better endothelial preservation as well as myocardial preservation, and that may well translate, we dream, in terms of the incidence of acute rejection of the allograft. And if that's so, that probably will translate into longevity, which is a hugely exciting thing. So we're all, leading a pipe dream at the moment, but if it turns out to be true, that's very exciting. There are 6 centers in the country. We've been pushing DCD, and our waiting list has fallen catastrophically as a result of the introduction of DCD across time. And this is exactly how it should be. The others are a little bit more cautious with this novel program. Comparing normothermic regional perfusion with direct procurement, that is this is in situ. I beg your pardon. Forget what I'm saying. Here we've got DCD, we've got DBD. Looks as though the DCDs are ventilated recipients are ventilated for a bit less time. They're on ITU a bit less. Small numbers, so we've got to be cautious with that. But it looks as though it might be something to keep an eye on as time goes by. Comparing in situ resuscitation, we only had done 12 at this stage, and a reasonably matched group of direct procurement cases suggested no significant difference between ex situ and in situ recovery of organ function of these ischemic hearts. But what we have seen, and now we've collected 157 cases of TA and LP, the resuscitation inside the body, we're getting a very low rate of rejection, and that's it's still small numbers. We have to see how that goes. We've got tens of thousands of brain dead transplants to compare to, and to have 23 or even 150 up your sleeve is a bit paltry. But why would we use machine perfusion of hearts? We can restore function in ischemic hearts, the DCD heart, and regain that function so much so it can be transplanted. We can nourish and preserve the hearts outside the body, and that's led Big Pharma to saying, well, we can start looking at molecules of interest as first in man in your model. And so AstraZeneca and Moderna are employing us now to do that, and we're looking at a VEGF mRNA, and after a lot of preparation and a lot of shenanigans, we've done our first heart of a series of 4 for AstraZeneca, and they've got a series of molecules already that they want to look at. But we can modify hearts, and Mike Nicholson, renal transplanter next door in Addenbrooke's, is, for example, knocking off the various sugar molecules from the genome in kidneys, so that there is no AB antigen expressed, so that in the short term, all kidneys will be seen by the recipient as blood group O. Of course, these organs will recover the ability to express HB antigens, and it appears that with the small amount of transplantation that's gone on, mainly in animal work, that there is a sort of mosaic and a period of sudden acute rejection, increase in acute rejection, which is hugely exciting, because if you can make all hearts universal donors, blood group O in effect, everything changes in terms of organ allocation, which is great news. But most excitingly is this, and this is what you're all going to be doing. You're not going to be doing this Inca procedure of taking hearts and switching around the place, starting with a dead body. You're going to get patients in heart failure, and you're going to put them through a period of perfusion, isolated perfusion, so that you can use high agents. And it appears that we can reconstruct the signal pathway that is intact in the liver, but interrupted in the heart and central nervous system, so that the mRNA switch to myocyte or neuronal reproduction is restored. That's been done in the myocyte side of things, has been done in the mouse very successfully. difficult to switch off. So the team are using, I'm told, short-acting, short-duration mRNA, and we're going to use the Morgan, the Langendorf we have on rejected human hearts or explanted human hearts at transplantation to test the hypothesis and see if we can see evidence of recovery of that impaired signal pathway to switch on myocyte reproduction. If that's so, we're well on the way towards having a program of repair of ischemic cardiomyopathy, 50% of the workload of transplantation in this country anyway. And that is just a wonderful point to reach at the latter stages of my career. And I would suggest at the beginning of your career, hugely exciting. So we are vastly under-resourced in terms of hearts for transplantation. Thank God it means there is not an epidemic of young death. So along comes machines that draw blood from the poorly performing left ventricle and deliver it to where the left ventricle would normally deliver blood, into the aorta. That's all it does. But it requires a pump of various types. We used to use pulsatile pumps with valves and so on. We now use centrifugal pumps because they're it's a little kinder to blood. It does not quite so much hemolysis. And these devices are, this one in particular, this is a Levtronics, and it's a gorgeous pump associated with a lot less thrombosis and therefore stroke than its predecessors. And it seems to be durable, and clever innovation within here means that it doesn't require bearings. It's a magnetic elevated centrifuge, so there's no surface-to-surface direct contact, and blood passing through is used as a lubricant and cooling device. So it's a very, very clever design. But nonetheless, there is an issue of stroke. There is an issue of infection and pump failure. And there is, of course, an issue of not being able to afford it. It's incredibly expensive. And this is the sort of kit you have to go around with. And it's things have come along a lot since the early days. The first person I put this into was rather a chubby guy who was a bit too big really for heart transplantation. So he was a plumber and liked to get up into the lofts, and he told me how difficult it was wearing this with his external batteries because they got stuck between the rafters. And then he rang me one day and said, "Look, I'm rather a long way from home. I'm in the car, and I haven't got enough battery to proceed, and probably not enough battery to get home. What should I do?" And I said, "Tell me that you're in the car and somebody else is driving." And I said, "The answer to that is, yes, sir, somebody else is driving." Of course he wasn't, he was driving himself. And we told him not to. So I said, "Look, for God's sake, get your driver to drive you back safely and get your batteries," which is what he did. And he did fine, got transplanted, and unfortunately died of a fatal hemorrhage from one of his wounds, a wound in his leg to help his heart transplantation. But a memorable tale, and life is filled with these extraordinary, courageous patients. A thing called the what do they call it? This is a registry, Intermax, that's it's set in very big letters, of the category of patients, the number of patients that have been registered through the International Society for Heart and Lung Transplantation who had bridged to transplantation. That is somebody who is so sick they would be normally taken off the list because they're too sick for transplantation and probably wouldn't survive until a good donor came up. So they're bridged with the support of a left ventricular assist device, or indeed a biventricular assist device, one on the left and one on the right. There are some folk who are clearly not candidates for transplantation, period. But very early on, we found that if we put a left ventricular assist device into the left ventricle, the high resistance as a result of vascular change in the lungs changed very quickly within 3 months, and you could then become a candidate for transplantation. The Americans call this rather clumsily bridge to candidacy. Destination therapy, I was in the early days of trying to work out, firstly, whether this is the right term, and then who should go in for this, and indeed who should be monitoring this development. And my suggestion of a priest being on the board was met with derision. But it's the destination, as I said to them, is, we know the station we're leaving from, but the station that we're looking to achieve is death, of course, and but solely supported with a device. Patients break out of this and get transplanted, or of course die with their machines in place. And then the very exciting area of bridge to recovery. And this, I described 2 cases for you earlier on of myocarditis. And that's when you've been into that room, you've seen people who've recovered their old heart function, their own heart function, and you compare it to folk who are requiring lifelong immunosuppressive agents, takes you to a point where I really want to be. And I've seen a smattering of it, and you will see a lifetime of it. And it's going to be like changing tires on your car. It's going to be, I predict it's going to be a magnificent step forward. And I hope I'm right in that prediction. I'm not sure what that means financial, because the surgeon needs a new kitchen. No, I'm teasing. So here, just showing the sort of Kaplan-Meier, if you will, the proportion of patients surviving or suffering the inflictions. Here, we've got the proportion of patients who've got assist devices. Here, explanted, a small group, implying recovery. So it's a small but very, very prominent issue. Those that go on to transplantation, quite a few of them, 1 in 4. Those that die, 1 in 5. And those that are alive with their devices and declining with time through death, eventually, of course. But people are now saying here out to 2 years, there's reasonable data to 2 years, some suggesting we've got enough numbers to make sensible decisions at 4 years, that the early results of the very sophisticated machines now are actually showing that machines are going to compete with hearts, donated hearts. I have my doubts, but I hope that's right, because that, but for cost will resolve a huge problem. So it's very exciting. Here's the machine that is a monopoly. Every time we use this, we have disposables that costs the Transmedics about $1,800 to make, and they sell it to us for $75,000 because, like any first mover in an area in a new innovation, you bear so many huge costs. They've been going for about 26, 27 years now, but it is eye-wateringly expensive, and beyond the revenue of the NHS, the health service budgets of anywhere in Europe. Spain has adopted thoracoabdominal NRP with no machines, no need of machines, just cold storage afterwards. And a number of centers in the States have adopted the same with spectacular results. And those we're just publishing shortly with our own results. And this, of course, is the answer to the challenge of that financial layout in the Transmedics. It's a Langendorf device, and we're just learning about the rigors of going through the regulatory authorities to get this thing into market, so that all units in the country can have one, and the DCD program continue. So exciting stuff. We've made our machine a certain size so it fits into a CT scanner. We can do the longed for angiography that has not been available in so many hospitals to date. And here, for example, is reconstructed LAD showing no significant disease, and therefore, at least in this area, no reason to turn the heart down. And that can go off and be taken vital, perfused at 34 degrees centigrade, and stitched into the recipient after cooling down in a swift period of implantation with great results. The problem with long-term perfusion, and this is what our latest student is doing his PhD on, preload recruitable stroke work, is much the same. It's not quite as elegant as the SPVR, but it seems to be closely associated with with ESPVR. And we see that that deteriorates. It improves with time and then deteriorates over a period of 8 hours of perfusion, which is exasperatingly short. Stroke work deteriorates. And we're looking at the rate of pressure change, the maximum rate of pressure change, similarly tied in with preload recruitable stroke work. The minimum pressure change, describing probably the edematous state of the heart, possibly the metabolic deterioration of the heart in this 8-hour period, and then the stiffness of the heart with this peculiar tau thing towards the end of diastole. So a lot of work to do to try and get this thing up to being effective. So I leave you with this, and here we have our patient, unrealistic because looking forward for a transplant, and she's ambled down to have a look at the banked shelves of hearts. I don't think we're too far away from banking. I don't think we're too far away from you guys saying this isn't good enough. We're going to repair these hearts, and we'll repair them outside the patient to begin with, but then we'll do isolated perfusion in vivo. We can use the term vivo because there is vivo, the patient's alive. And that's very exciting. So I'll leave you there, and I hope there's a number of questions if that's any help at all.
Thank you so much for